Hi, everyone who's coming in. Thank you for joining us on this honestly beautiful spring day. I feel like it's been false spring for like a few weeks, give or take, but I'm hoping that we'll have a little more sunshine in the coming days. We're here to discuss pediatric healthcare in immigration detention with some really remarkable panelists. I'm really honored to be here. My name's Christella Guerra. I'm a senior arts and culture reporter at WBUR. I also cover immigration at most of the places I worked over 18 years as a journalist. And I have the honor of being a Nieman Fellow this year at Harvard. And I took Professor Baba's migration class in the fall. So I'm just very excited for this conversation. I'll turn it to Maggie for introductions.
Thank you so much, Christella. Good afternoon. I'm so grateful to be here today with everybody and to introduce this really impactful group of advocates and scholars. My name is Maggie Sullivan, and I'm an instructor at the FXB Center for Health and Human Rights at Harvard and a contributor to this report on child migrants and family detention that we'll be talking about today. So taking one step back, Cristela Guerra is a senior arts and culture reporter at WBUR in Boston, who identifies as a queer Panamanian journalist of color and leads conversations around race, identity, and equity. She has received the prestigious Edward R. Murrow Award, most recently in 2023 for her work at the U.S.-Mexico border on the journey of Venezuelan migrants. Professor Jackie Baba is a professor of the practice of health and human rights at Harvard T.H. Chan School of Public Health, the Jeremiah Smith Jr. Lecturer in Law at Harvard Law School, and an adjunct lecturer in public policy at the Harvard Kennedy School. She's also the director of research at the FXB Center for Health and Human Rights at Harvard. Javier Hidalgo is an attorney who specializes in asylum, civil rights, and complex litigation. In 2018, he joined Raices, the largest immigration legal aid agency in Texas. As the legal director, he oversees trauma-informed programs in support of individuals, families, and unaccompanied children, both in and recently released from government custody. Dr. Katie Peeler is a pediatric critical care physician at Boston Children's Hospital and an assistant professor of pediatrics at Harvard Medical School. She's a member of the faculties of their Center for Bioethics and the Department of Global Health and Social Medicine. Dr. Peeler is a co-medical director of the Harvard Student Human Rights Collaborative Asylum Clinic and engages students in research and advocacy efforts through the Peeler Immigration Lab. Thank you all so much for being here today.
And I think folks know this, but later on in the conversation, we'll be taking questions. So definitely, as things come up, if you want to engage with us, please put your questions in the Q&A, and we'll try and address them. I think they're in the chat. I know that folks, our panelists have some remarks. So Professor Baba, would you want to open us? And then Katie, I'll go your way.
Thank you so much, Christella, and thank you to all of you who are here today. I absolutely agree with Maggie that this is a really remarkable and very important piece of research that I'm proud to say the FXB Center contributed to. I'm just going to make a couple of very general comments about why this report is so important at this time. So first of all, as the report says, thousands of children continue to be detained in the US simply because they are migrating in various different statuses, not because they are charged with any criminal wrongdoing. So a basic principle, which is that children should be considered children first and foremost, is violated in the US every day in respect to migrant children, the thousands of them who find themselves in detention. I'm a human rights lawyer, and one of the basic precepts that we learn and we teach is that for every single child in the world, their best interest should be a primary consideration in all public government actions affecting them. What that means is that whenever a government is interacting with a child, including, for example, when a government is detaining a child, then the government has to have the child's best interests as the primary consideration. Primary doesn't mean exclusive. It doesn't mean that you can't have other considerations. It doesn't mean, for example, that you can never detain a violent child, but it does mean that you, as a government authority, for example, a prison authority or a detention center authority, have an obligation to think and consider the best interest of the child as you develop your policies. That's the cardinal rule. So where you read, as we do in this report, that routinely children are not properly screened for health problems in detention when they're in government custody, where you read that routinely children's medical records are not properly maintained when they are in government custody, you have to ask yourself, how is this possible? How can this continue to be the way in which government is conducting its business with respect to some of the most vulnerable children within their custody? And the last thing I'll say in opening is that, to me, as a human rights lawyer who's worked, like Javier, in the migration field for many, many years, it is extraordinary how little attention we paid to this gross dereliction of duty in the medical context. There is a lot of work done on family separation, rightly so, because it is an egregious issue. There's been a lot of work done on the unacceptability of commingling children with unrelated adults in custody. There has been work done on appalling detention conditions. But surprisingly, maybe, there's been very little work done on the topic that this report addresses, which is how the medical care, physical and mental, that children are given is administered, and who performs it and how it's recorded. And so I think that this report, both what it documents and what it recommends, should have a very large impact. And I hope it really does contribute to changing the way in which business is done with respect to these children. So I'll leave my comments at there, Christella. Thank you.
Thank you so much, Professor. Dr. Peeler, would you like to go next? I know you have slides as well.
Yes, thank you so much. Let me just put these up. All right. Are those visible to you, Christella? Yes. Okay, great. So thank you again for having me here. I just want to acknowledge the FXB Center and Raices and the group at Mass General for putting together this report. And just to note that I have the honor of presenting these findings, but I am a teeny tiny author on this report. It was really done by another group of people many were in the audience, as well as Maggie and others. So I just want to go over some of the findings and kind of talk about, expand a little bit upon what Professor Baba said in terms of why they matter. So essentially kind of what was done for this study is that Raices, the legal nonprofit that was kind of doing some work at the Carnes Family Residential Center in Texas, had been collecting medical records of children whose families they had been assisting at that center. And they had done this both to kind of help these children in the acute phase, who they felt like their medical care was not being properly attended to, as well as for potential research. And consent was obtained from all the families who agreed to have their child's records be part of this study. The group actually originally asked for many, many records, but ultimately ICE, who is kind of responsible for this center, agreed to release the records for 165 children. The 165 children were between the ages of 6 months and 18 years, so really a wide range, which is important because a 6-month-old is developmentally and physically and mentally very different from an 18-year-old. But as you'll see in the future, they were commonly treated similarly. And these were children who were at the Carnes County Family Residential Center between June of 2018 and October 2020. These records were then evaluated. These were kind of standard intake records, acute care visits, mental health records, and growth charts. And they were compared to guidelines that are meant to be followed within these settings, guidelines set by ICE, guidelines set by the Flores settlement agreement, which is a legal agreement about how children in government custody are meant to be cared for. And so that was the methodology. What was found is that of the 165 children whose records were looked at, 88% of these children were held in this detention center for more than 20 days. And this matters because per this Flores settlement agreement, which I had mentioned earlier, which is a legal agreement which has just changed status actually a couple of days ago, but a legal agreement that says it limits the amount of time children are meant to be in different types of custody when working through our immigration system. They are certainly not meant to be held more than 20 days, but as you can see here, the vast majority were. So in violation of that agreement. Acute medical care was very frequently sought by this population of children. And so if we just think more broadly, right, kids get sick, it's not necessarily uncommon to go to see one's pediatrician or go to the emergency department if someone has an acute need. And so 82% of children in this cohort were seen at least once for an acute visit at the medical services within the Carnes facility. And 40% were actually seen more than 3 times. So there were a lot of acute medical needs. Frequently, it was for things like coughs, colds, diarrhea, but there were also more serious considerations that came to be. And 8 visits actually ended up leading to transfer for the on-site infirmary, and 14 visits actually led to transfer to a local hospital. Oops, sorry. Additionally, one of the major findings, as Professor Baba had alluded to, is that there was inadequate screening and addressing of many things, one of which was malnutrition. So, and this I think is actually a little bit of a nuanced finding. If you were just skimming through these records, you might not recognize this, but because the people who were looking at these findings were pediatricians, clinicians, and other kind of experts in this, they recognized that there were actually really big problems with how these screenings were done. So specifically for malnutrition screening, the CDC, which is one of the guidelines that ICE and ICE Health Service Corps is supposed to be finding, the CDC itself recommends not using the CDC's own growth charts for children under 2. It recommends using the WHO's growth charts because those norms are more established and it's a more appropriate way of measuring the growth of children in this age group. And so in the charts that we looked at for this study, it was found that 13% of children under 2 met criteria for acute malnutrition when you were looking at these charts. But in reality, that probably was an underestimate because they were using the CDC charts. They were not using the WHO charts for this population of children. So even that number that we have is probably inaccurate and it is probably an underestimate. In addition, the research group also looked at different ways that malnutrition manifests, some of which are related to weight, some are related to weight for height, others are related more so to height. And I'll leave all of the people in the audience to read more about these definitions in the report, but functionally there was a lot of malnutrition, which is not surprising in the sense that we recognize that a lot of children who arrive at our southern border may have malnutrition, but it was surprising how much there was and how unattended to it was. So 4% had moderate to severe wasting. 12% were found to be what we consider at risk for malnutrition, so they were just on the cusp. 23% had stunting, which is more height related, and 6% had severe stunting. And despite noting all of these things, there was no real follow-up or addressing of these issues in the records for these children. Another large finding was about mental health screening, and it was really of limited utility, and there was inadequate follow-up. And so I mentioned to you that the age range was 6 months to 18 years old. But despite that, every single, on the one hand, all 165 children were screened for mental illness on intake. On the other hand, the questions were the same. So asking a 6-month-old about suicidality is, I am not even quite sure what to say about that. And so there was no kind of nuance for the developmental or age level of the children in terms of who was screened for what types of things or what they should be screened for. Additionally, of the screens that were done, which again was 100% of the population, only 2 children had a positive mental health screen, despite the fact that we know in the literature that there actually is a much more large proportion of mental health disorders within this population, as seen by many other both research studies as well as studies by the Office of Inspector General. And then the children that ended up going and being seen by mental health providers, only 5% of them in their mental health notes actually had an abnormality noted. So it wasn't even clear kind of what they were being seen for. And then the visits that did occur, in terms of the reasoning, it was often noted that it was initiated via parental concern, i.e. not from a screen, meaning that the screening was probably ineffective because people felt that they needed to make these visits on their own. And lastly, I just want to close with a little case example that kind of exemplifies a lot of these things all rolled into one. So this was an example of an 8-year-old boy who came from Honduras. On the day that he arrived at the Carnes Center in Texas, he weighed 65 pounds, which was normal for his age and height at that time. And then around 3 weeks into his stay, his family requested an acute visit because he had been, they had said that he had been inappropriately touched by another adult. And so there was not actually any record of what was done with that, other than the fact that he was referred to mental health care. But he wasn't seen by a mental health specialist until day 36. So quite a long time for the fact that that's a fairly significant allegation. At this mental health visit, the mental health specialist noticed that he had lost weight. He had lost 3 pounds from not eating due to emotional distress, was noted. And so he was referred back to the non-mental health, the traditional health office within the center. And he was noted actually to have even further weight loss. And while he continued, at that point in time, he was started on micronutrient supplementation, and he actually did continue to see mental health specialists. There was never any mention of the fact that he had told other people in the center that he was experiencing suicidal thoughts. There was no mention of kind of what was being done about this, and he ended up actually staying in the facility for 82 days. When really what he probably needed, again, as Professor Baba alluded to, was to not be in detention, as well as to be connected with mental health resources outside the facility, probably have food that was more appealing to him, and just generally be in a setting that is more conducive to care and being a child. And so why do these findings matter? I'm going to stop sharing my screen and just to say they matter because, as Professor Baba mentioned, really the child's best interest is meant to be the primary consideration in these settings. And so detaining a child is never in their best interest. And particularly for this period of time, and the fact that 20 days is our marker, 20 days is already too long, and all these children were being detained for well longer than 20 days. And there's many violations of this settlement agreement, which I suspect we'll talk about a little bit later. And there were also just many instances where the care was inadequately documented. It was unclear who was providing the care. A lot of the care was provided by practitioners who were operating outside their scope, so LPNs or RNs, who are wonderful parts of a care team, but they are ultimately not responsible for the care of a child. It should be a pediatrician or someone of equivalent training, and that was just really lacking in these charts. It was very hard to read these charts. When we started this project, I remember there was a lot of discussion about how to read these charts accurately and consistently, because the actual documentation was really, really poor. And so it's hard to really know what's going on there. But overall, it was just very concerning that the care was inadequate, the screening was insufficient, care was one size fits all, despite the fact that, these children were from many different backgrounds and many different ages. And ultimately what they really needed was to not be detained. And so happy to talk more about policy stuff later, but I will pass it back to you, Christella. Thank you.
Thank you so much. Javier, did you want to speak on this?
Yeah, thank you. And I'll start by expressing my gratitude to FXB and Mass General really for the collaboration to allow this report to happen and the study to happen. Sitting here and reflecting, one of the things that really stands out is a lot of things that the report does. It confirms what a lot of the legal practitioners who are going into these detention centers know and see. But one of the hallmarks of ICE detention is really the difficulty around transparency, right, and around access to any kind of accountability, right. I think this is an important. This report and this study is a hugely important step in the right direction to to start kind of breaking down those walls, which are by design, right? I want to give a little bit of context around the Carnes Family Detention Center, which even the name is a little bit of a moving target. But the huge takeaway, right, is what we're talking about is that at the time that our government was detaining families together at Carnes, what that really is putting children into an adult prison setting, right? And that's what the huge majority of ICE detention is, right? It's we're detaining folks who are coming to the United States, families and children that when we're detaining families who are seeking the protection of that's illegal, that could potentially be legally provided by the United States, and we put them into adult prison settings, right? And these are privately run facilities run by private contractors, and there's multiple layers that create just kind of hurdle after hurdle around accountability, right? The huge takeaway is that it's never appropriate to detain children at all, right? And especially not in these types of settings. Nor is it really appropriate to detain anyone in these type of settings, for these purposes, right? It's putting people in a punitive setting for what really is a legal process, right? But the huge thing that really just sticks with me, right, is that this is just really the tip of the iceberg, because it's so difficult to really get access to the type of information that can really allow us to speak to it, right, and show it in a meaningful way. So this opportunity to do so, I think, is hugely important. It's easy. And again, I mentioned by design, right? It's easy to treat immigrant detention as a over there issue, as a border issue, as a Texas issue, right? The way that the system works, it tends to be a black hole, right? There's several layers of several stops in the detention process, right? Folks are detained in CBP facilities before they end up in ICE detention facilities, it's very easy for someone to get lost in that system or be hidden, right? The reality is these are folks that are coming to the United States that usually have community here and are going to end up in community here. We've had just the population that we've worked with, we see them once they get through and out of immigrant detention, if they do, right? Because the unwritten kind of goal of immigrant detention is just to be a hurdle to accessing the asylum process and really get people to get deported back to their home countries, usually back in violation of what's called non-refoulement, right? Sending people back to harm before they have an opportunity to legally seek protection from that harm, right? But if they make it through immigrant detention, which is a reminder that it's always discretionary to detain. The ICE always has the discretion to release people from detention. And so when a child is held 82 days, ICE, from day one, ICE had the discretion to release that family and that child, right? That's an important point. They end up in Massachusetts, they end up in Maine, they end up everywhere and in community with their family members and community. And so, this is not a strictly border issue or a Texas issue, but it's easy to see it that way because of the layers of obscurity that comes from this type of system, right? And so I think my biggest kind of point is that creating that accountability is a huge goal. The larger conversation about is there any redeeming value in immigrant detention at all, right? I think is an important conversation that I hope this leads to. And really just questioning this whole process. One last thing that I'm reminded that I wanted to make the point. Carnes was family detention, right? And there's all different ways that children are detained in this setting. You know, while the government maybe today isn't detaining families in that same way, that there was never an official act to end that process, and it can happen tomorrow again, right? And so these are things that I think, absent these types of studies, those conversations that can really put the pressure on to do the right thing can't happen, because it's easy to happen. It's easy to do these things in the shadows. And so I'm just really grateful that this is an opportunity to shine light on what's going on, right, in our country today. So thank you.
Thank you, Javier. So we can start our conversation, but I also note that there are questions already in the Q&A that we can. I'm wondering, you know what? I'm open to beginning with this. This is actually kind of interesting. And this will be for everyone. Who is ultimately responsible for the care of these children? It may be claimed the pediatricians have responsibility, but they are not responsible for the detention. Who can be held to account? And with that, I'll note sort of a personal anecdote. I think Professor Baba knows this. My father was a pediatrician of 40 years. He worked with kids all his life. And we're Panamanian. We came from Panama. And he was a doctor there, and he was a doctor here. My mother is an RN. She was a nurse, or she is a nurse still. My dad passed late last year. And there were opportunities for him to work in some of these facilities. And I think at points we discussed it, but he sort of understood. He wondered if the values he holds around like taking care of kids, of anyone, not just of immigrants, and he mostly worked with immigrants, would be maintained at the border and other facilities where it often felt like there was never enough help, let alone the hours I think they were offering for that kind of labor. So I sort of acknowledge that the system itself is broken and reform has been needed for a while, but that you have pediatricians out there who are constantly getting asked, is this work that you want to do? And will they take care of the kids the way that you do privately in your practice? But yeah, I would say that's a good start. That question about who can be held to account for this.
Christella, if you don't mind me just jumping in, even though this is, I think, where Katie and Maggie have more competence as trained medical professionals. But I would just say that I think the point you raised on the example of your father is really important. In the history of the intersection between human rights and medicine, there's a long tradition of doctors refusing to do unethical examinanations in unethical contexts. I'm thinking, for example, of, doctors being asked to intervene in most egregious cases are kind of like torturing detainees in Turkey, for example, and all sorts of practices. And there's been a lot of work by, ethical medical professionals to say that we cannot agree to act as medical professionals in certain contexts. And I would say that if you have a situation like the one that Katie just described and the report describes, where records are so poorly kept that you can hardly decipher them, where a child who has suicidal ideation is kept in detention when he's no danger to anybody for over a month. This is a situation in which maybe there's something to be said for doctors and nurses organizing to say, we have our Hippocratic oath, we have our basic codes of conduct. We cannot be party to this. So I think it's of course, the authorities are ultimately responsible, the authorities that are detaining the children, ICE, Department of Homeland Security. But medical professionals, too, have agency. And I would have thought that this is a very important point you're raising.
Yeah, thank you for that question. And I agree with Professor Baba. I think it's, I just put in the chat, one of the links might not quite work, but a very old but certainly a very still relevant report done by Physicians for Human Rights about 20 years ago on dual loyalty. And another example to add to Professor Baba's example was what was happening in Guantanamo and the psychologists that were complicit in creating methods of torture for people who were being detained. And ultimately there was a big uproar, and they said, we're just following orders. And eventually the APA had to say, actually, you can't be members of our organization. But originally the APA was also complicit. And they had to kind of change.
Could you just say what APA stands for?
Oh, sorry, the American Psychological Association. Ultimately they realized, there are certain ethical standards to what it means to be a care provider. And I think it's really hard. So I think to the person who asked that question, first and foremost, I would say ICE, so the Department of Homeland Security, under which ICE operates. And then today we're not talking about ORR, but the Office of Refugee Resettlement, which is under the Department of Health and Human Services. Those two bodies are responsible for the care of those children. And so oftentimes they will say, well, ICE Health Service Corps is the one who's doing the care. Or, oh, well, it's the private for-profit prison corporation who's running the facility, like Core Civic, and so let's blame them. Like, oh, or it's Congress. Congress doesn't fund us enough that we don't have enough money, so we can't hire enough psychiatrists. And so there's a lot of passing the buck in this situation. And I think there's two things that are important. On the one hand, dual loyalty for clinicians, meaning that you have a loyalty to your practice and to the ethics of being a pediatrician or a psychiatrist or a nurse or whatever it is to care for the person in front of you, comes into conflict when you are working for an organization whose primary goal is to do something that is inherently not helpful to the health of that population. And there was an op-ed written by Dr. Ranit Mashuri in I think it was in JAM, I can't remember, and I can find that and post it too, where she cut and pasted an ad from one of these detention centers saying, seeking clinician needs to be board eligible, not even board certified. And it was for some insane amount of money, like $300,000 to be a clinician. And must adhere to the mission and goals of this institution. But the mission and goals of the institution were to keep people detained. And so that ad was quickly taken down from the medical journal it was placed in because people were alarmed that someone was being paid. None of us get paid $300,000, just so the audience is aware. It's not a salary that most of us make. And certainly not when you're right out of medical school, and certainly when you're not even board certified. And so, but you can see how someone who has a lot of loans, and maybe they really do want to work with this population, like your father, Christella, who they want to be a good doctor. They're like, this sounds like a great gig, but at the same time, I don't believe in this institution. And so it's really hard. And then there are people who don't have good, desires who work in these places. There's really a mixture of both. But I do think that it is both the responsibility of the governing body, so ICE or ORR, as well, and I think the pediatricians and those who work there to provide good care. But it's tough because I've had attorneys tell me, please just stop applying for these jobs. If none of you apply for these jobs, then they will have to shut down these centers. And you can see where that thought process comes from. But on the other hand, it doesn't feel great to leave these kids without people to care for them. So there's not a straightforward answer, but I think it's very complicated, but it's an important question. And I think it's important to kind of keep everyone responsible and not let people just pass the blame to others.
Did you have anything to add, or did you want me to move on to the next?
You can move on. Katie hit what I was going to say is that the relationship between ICE and the various contractors, it kind of varies, but it's all about kind of passing the buck and pointing fingers. And so, but generally in ICE detention, ICE is ultimately responsible, but what you'll see is a lot of that passing of the buck.
I'm curious about the origins of all of this, especially considering how difficult it is to get medical records. Obviously, families have to approve. And then you have to sort of, I think, Dr. Pila, to your point, the sort of the backwards work of deconstructing these records and understanding what was happening when you're not there, right? It was a few years back. And I know, Maggie, you were on this report. I mean, could you speak about how it came about and the hopes for this data? When you were starting this whole process that seemed like a bit of a monumental task. What were you thinking about?
Go ahead, Katie.
No, Maggie, I was only unmuting to say, Maggie, this is all you.
Oh, well, I think to Katie's point before too, there are also not just people, but leaders of this academic work and the report, and really important advocates who are in the audience today who could also really answer to this. But I do think that this is one of the reasons why, professionally speaking, it is really important to have documentation. And when you have, there are standards for quality of documentation, and it is for reasons like this, that if you're able to go back and piece together something that had a negative outcome, what is preventable, what could we have improved, that you can trace back some of these things. And you can't really do that with spotty or handwritten or inconsistently kept medical records. And I think to Javier's point about transparency and this being a black hole, that continues to obfuscate the what is happening in these spaces.
Others?
Yeah, I think I can speak to a little bit too, and I should thank really the team at Raíces that really works directly with these populations, both current and former colleagues, that really saw the pattern, right? What we would observe a lot, right, is our clients are coming to us and telling us that this X, Y, and Z is happening to their child, and we're like, okay, did you go to the medical services? And they're like, yes. And they told us, whatever ridiculous answer that they would get, right? Or we can all see the child, losing weight rapidly, and them being told, oh, there's nothing wrong with the child, that's normal, right? And so, it very quickly became apparent that, like, well, okay, well, you saw the doctor, you should have access to your medical records, right? And that was kind of the part of the organic kind of impetus for, like, let's try to get your medical records to you so we can review what the doctor actually did or said. And sometimes, an example was like, dental care, and then there would not actually be a dentist on site, right? And so, like, all kinds of scenarios kind of starting bubbling up that we could see those patterns, right? So it became really apparent that the value in trying to obtain these records that for use like this, and or for being able to advocate more actively in that case, right? If we were trying to get urgent medical care for one of our clients, and for one of their children that we're working with. So I think it's probably a common experience of folks that are working with these populations in detention centers, that they would see that kind of that anecdote of I went to the medical center and they wouldn't help me, right? And if I went back through all the stories, I think it'd be kind of horrible. But it is a pretty common occurrence that it's clear for us who are not medical professionals that what they're getting is wholly inadequate, right? And so it was that clear to us. It was pretty apparent that, like, what do medical professionals have to say about this, right? Was a very early question of ours. So.
I think, just to build on what Javier and Maggie were saying, I think I've looked at a lot of these records, both for this report, but also in other contexts. And I think the thing that it comes back to me is also there's just the lack of agency on behalf of the family. So, there's another case that I did a very, very big review for, of a little girl named Maria Juarez, who died after being released from Dilley, so a different family detention center in Texas that Raíces has also worked at. And she was getting sick while she arrived. So it seemingly had a common cold, was getting sicker, and had a lot of acute care visits. And it was really hard to read the records. On the one hand, there were very obvious objective vital signs that were abnormal. And so those I felt very comfortable saying, like, I see this, it was measured by a machine, it's true, and I know what it means. And then there was other information where you had to really try to figure out, is this sentence that I'm reading just something that someone cut and paste, or it's from a drop down box? Because it doesn't seem like the fact that it says that the child is playful, but it also says that their temperature is 40 degrees and their heart rate's 220. I don't know. I have a feeling they're not feeling so great right now. And so you have to figure out what you can trust and what you can't trust. And it's really hard to know. And ultimately, that little girl was released from detention, not because she medically should have been released, but because her time limit based on Flores was up. And so she was released, medically cleared, no precautions needed was what her release said. And her mother immediately brought her to emergency care, and she never left. She ultimately was placed on heart-lung bypass and died in Philadelphia after a complication. And she had what was a common cold, in all honesty. And like, you can't blame, like, that could have occurred anywhere, right? Daycare. But the fact that her mother had no ability to do anything about it, she did as much as she possibly could. She kept on bringing her back over and over again to medical care, but she couldn't just say, like, this is not good enough, and say, like, I'm bringing you to the emergency department, or this emergency department is terrible, I'm bringing you to a different emergency department. So she did that once she was able to do so, but she had no ability to do so between then. So when you're trying to understand what's going on in these detention centers, and the records are just very hard to interpret. It's just, and then you hear stories of children who don't do well. It's just very clear that the care is both inadequately given and inadequately documented.
I wonder, especially the questions noting we should switch to policy. Someone asks, understanding that detention does not lead to positive outcomes for anyone, what do you think the solution is to detention? And then I would pair that with the next question: what system level changes would need to be in place to ensure children are safe and receiving adequate care, especially in the systems that are heavily burdened? I would note that when I was at the border, we visited a few sites. I was there with attorneys from Boston that were investigating the situation with the Venezuelans that were brought to Martha's Vineyard without their choice, who were told that they were being taken to a place where they'd receive housing and jobs and a brand new life. And they were just sort of dropped off in a random island, many of which I believe are on their way to receive visas because of the circumstances around that investigation specifically. But when I was there in the detention center in El Paso, there were kids playing in a corner with each other. There were a lot of people, but they were moving them along. And what I noted specifically was that it seemed just a different environment altogether from what I've heard of other parts of the border. So it shows how different maybe it could vary. There was fresh fruit. There were, circumstances where the families were being provided for, but they were also immediately being bused to DC, to New York. And, then I would meet up with, I didn't meet up with the same families, but I met families who had come from the border to kind of complete the arc of storytelling to understand how that journey was. So Professor Baba, if you could just sort of, what options are there? I'm sure there are options.
Absolutely, there are options, Christella. First of all, in many contexts, countries don't detain in the way in which the US detains, certainly don't detain children. There have been experiments in this country too in the past where attempts have been made to parole people out and give them return dates. And the evidence suggests that if you tie people up with legal representatives, they do show up, generally speaking. The idea that everybody absconds is not borne out by the data. So the point is that the system has to invest in this. It's not, and detention, as we all know, is hugely expensive. So it's not a cost-effective solution. A much more cost-effective solution, just even leaving the rights element aside, would be to parole people out and to have lawyers, pro bono lawyers, publicly funded legal representatives, trained people who can then counsel people and advise them on their rights, whether they have a case or they don't have a case and so on. And people then would show up in court. So the first thing is you should really be absolutely drastically reducing the rate at which people are detained. And as we said right in the beginning, For children, there's no good reason to detain a child. You can find where a child is. If you give them, you have an address, you know where they are. They're attending school if it's for a long period of time. There's no reason why a child should be held in custody when they're not a danger to anybody, when they're not charged with any criminal wrongdoing. So that's the first thing, I think, which is just to radically reduce the use of detention. And, we've mentioned the Flores Agreement, which said that it should be a last resort. Last resort means that you explore other options first. It's common sense. But here it's a first resort, and it's used in a way because it's, this is kind of very much a political decision, I think, that's being made. So that's the first point I'd make. The second point I'd make is really picking up what you said, Christella, that the people who work in these centers should have to be subject to training. They're handling children. They should have to prove that they have training to deal with these children. When we did research years ago on detention of children, this is decades ago actually, we found that the people who were holding the children had no idea. They could have been holding animals, or cardboard boxes. They had no idea of what it is to have a child in your care. You can't blame them. They were never trained for it. They're just, paid to kind of enforce the rules of keeping people in. And so when children would say, well, what's going to happen to me? They'd say, oh, I don't know. And they generally didn't know. They had no idea what the process was. So children who are frightened, who have this terrible sense of precarity because they don't know what's happening next, when they're going to next be able to get out, to lead a more normal life, to meet relatives. When they ask the people who are supposedly in charge of them for explanations, they get nothing back because those people don't know. All they know is they're in charge of this little box. They don't know what the next box is, and frankly, they don't really care. So the second point is that those who are administering these places must have training. They must be subject to certain norms and expectations. And similarly to what you said about food and hygiene, children, there have been reports done showing that children don't brush their teeth. Children don't have minimum hygiene in some of these places. Again, this is a gross violation of responsibility. And I think that, I hope this report leads to a much more thorough investigation on a bigger scale. That's why we have a monitoring system in the UN human rights domain under the International Covenant on Civil and Political Rights, for example, where you could have a complaint and you could have a committee coming in and actually investigating. Of course, you need permission from the relevant government, in this case, the US government. But, it's egregious that these sort of procedures continue, that the substandard food, that the places that children are kept in are absolutely freezing cold and inhumanly cold for people who are used to a hot climate, etc. You could just list the complaints. And this is just leaving aside what this report specifically deals with, which is the medical issues. So absolutely, there are alternatives. There are much better alternatives. It's really a question of political will, I think, and it's down to all of us to contribute to changing the direction.
I'll just want to add to that point that it's actually ICE has done studies on this themselves. So I put a link in the chat to an op-ed that some of my students and I wrote, but it was really the students who did the bulk of the work, showing that to Professor Baba's point, people do not want to live in the shadows. That's not like a great way to live. People want to be able to go to school, go to work, and feel comfortable, and knowing that there's not going to be a workplace raid. Like it's and so people prefer to have some sort of official status. And so many studies have shown that when you have people who are seeking asylum or other some forms of immigration relief, and you don't detain them, they show up for their court dates. They show up for their asylum proceedings because they want to move that process forward. And when you do that, it is much cheaper. So the cost analysis in that paper showed that alternatives to detention are a fraction of the cost compared to detaining a person. But there is, the papers that article cite things that I don't love. Like I don't like ankle monitoring. I think there's ways of people being out of detention that are also still more humane than what we are offering, but it's less expensive, but they're just, as Professor Baba, there's not a political will. But I think particularly with family detention, which again, I think Christella or Javier, I can remember one of you mentioned how it's not currently happening, but could happen any moment, which is true. These children have have adults who can care for them. These are not unaccompanied children who need an immediate placement while we figure out where to put them safely. They're with safe adults. And so I think to ever detain them just makes no sense at all.
Yeah. And I'll just add, so prior to me working in immigration detention, I've never heard of the concept of civil detention. It only, to my knowledge, exists in this context. And immigration detention is just a huge contradiction, right? So civil detention under law isn't supposed to be used as a deterrent or as a punishment. It's not supposed to be punitive or deterrent. And that's exactly what immigration detention is. It's used as a deterrent and as a punishment for coming to the U.S. and seeking protection, right? Like we're punishing people for doing that. And so, it fails at achieving what its stated goal is, right? Of trying to somehow facilitate the welcoming and processing of folks that are seeking asylum here, which is a legal process, right? And it does, it serves arguably an illegal purpose, right? And what we're talking about, to everyone's point, right? These are choices. These are political will. These are choices around how we as a nation are spending resources. And so a huge amount of money and resources is going into the immigration detention machine, right? And profiting private prison companies that are contracted to run them. And that's a lot of resources that could be reallocated towards a welcoming process that connects people with legal representation, which to Ms. Baba's point, it's gonna, like, overwhelmingly, you have legal representation, you're going to show up because you want to obtain that status, right? To Katie's point. And so it's a hugely unnecessary mechanism that doesn't serve the stated purpose. And it boggles my mind that whenever anyone tries to justify the existence of this structure. But
I knew this hour was going to fly by. I didn't realize it would fly by this quickly. I wonder, I know it's 12:53. Maggie, I was wondering if we could do like a sort of a quick, there's a question here. Is there an expectation of HIPAA privacy? I believe there is. Is that a yes? Yeah. And then is there data or information around pregnant teens in this study and the quality of care?
So, that's a great question. And this was a space in which mostly male children and their fathers were detained. Not to say that all of the children were male, but the majority were. And so if you look at the demographics, I think in the paper or in the report, male children are overrepresented, and that's because of the way that the facility was designed. I don't recall personally that there were any reproductive or pregnancy related issues in female children that came up. I don't know if you recall, Katie. It doesn't.
Sheila just texted me, said no pregnant people.
Okay.
And then additionally, what is the fee structure for private detention companies? Who provides the monitoring / accountability for the well-being of each detainee? I'm afraid of that answer. Who provides?
Sorry, but
they're asking about the fee structure for per child and per adult, and then who or what provides monitoring accountability for the well-being, like who's in charge of that, I guess.
Yeah, I'd be curious to see what other people say too. The fee structure, I don't actually know what it is per person per day. I have looked this up historically, but haven't looked it up recently, and I'm sure it's changed, and it's probably negotiated differently between different detention centers, and who runs it and which private corporation is running it, if it is indeed private, because some are also, for adults, some actually ICE centers are housed in subcontract with local jails. But in terms of the oversight, that is a big problem. So there are many oversight bodies. So there is the Office of Inspector General, which is housed within the Department of Homeland Security. There is the Office of Civil Rights and Civil Liberties, also within DHS. There is the Government Accountability Office. And all of these different entities have rights to certain data. Some of them have to be asked to do oversight, whereas others just get to do oversight. And then the amount of kind of enforcement of their rules is very variable. I don't know, Javier and Professor Baba, with your legal background, if you have more knowledge, but my understanding is that CRCL has very little teeth in terms of being able to enforce the recommendations. GAO has a lot of clout, but again, the recommendations will go unanswered, not infrequently, and same with OIG. So
I would say the lack of teeth is the characteristic that immediately comes to mind with kind of all these mechanisms.
I would say that that's absolutely right. And just two additional points. One, that this complicated division of responsibility that Katie just outlined is, I think, deliberate. We once did a study looking at how many agencies interact with unaccompanied child asylum seekers. It was something like 24. And so it's hardly surprising that there's a complete lack of coordination that, both Javier and Katie talked about passing the buck. I mean, the buck doesn't stop anywhere. That's number one. And number two, I think that ultimately, going back to the point about political will, this is something that the community as a whole has to take responsibility for. There have been protests outside some of these facilities in communities, local people who know what's going on within their community, that there is a center holding children. Sometimes they are very removed and deliberately placed far away from, populated centers, but not always. And I think there again, you don't have to be a human rights lawyer or a pediatrician or a nurse who's working in the hospital to be protesting. And there are examples where local people have protested and have really highlighted how unreasonable this is, how local journalists, see people like you, Christella, highlighting this. So I think that it is really a collective responsibility not to leave this hidden. This is so often hidden. When you talk to ordinary people in the US, often they have no idea that children are being detained in these circumstances, children who have no criminal charges against them. It's a kind of there have been moments when this stuff has come to light, of course, during the Trump administration, and occasionally there are egregious cases when tragically a child dies. But, this is a tragedy that's just happening every day, and this needs to be something that communities take responsibility for. So I think the mixture of kind of lack of transparency, very, very broad and complicated delegation of institutional responsibility, and, the kind of willful lack of access and transparency are really what's contributing to the situation. So all to say that reports like this are so important.
No, we have 2 minutes. 1 minute. Maggie, can I give Javier, there's a question here about suggestions for advocacy and actions for community groups. Javier, I'm sure you work with a lot of folks in the community, but do you have suggestions for folks who are seeking, action items?
I wish I had a better list. I think elevating and kind of shining a lot of light on these issues is important. And getting the ear of the lawmakers that you have access to, I think it is super important, because I think one of the characteristics I've observed, right, is oftentimes the folks that kind of have power to make these changes, there's potentially a lag in information, or just a lack of information, and so they look to be educated on these issues, and that's, I think, a role that the different groups can play, right, is to really make sure that they're hearing the right voices and understanding the right issues, because otherwise what they're going to hear is, please put more money into border security because that's what we need, right? And then what that's going to look like is more detention, right? And so if they're hearing that, they have how many votes that they have to vote on, issues that they have to vote on. That's the basis of their information. So there has to be a lot more light shined on these issues.
Thank you so much. It just was such a pleasure to talk. Even for only 60 minutes, we could go for another 5 hours, I think. I pass it back to you, Maggie.
Thank you so much, Cristela and Javier, Dr. Peeler, and Professor Baba. On behalf of the FXB Center for Health and Human Rights, it's really an honor to be able to uplift this work that is oftentimes so hard to find and so buried. And I appreciate, Professor Baba, your kind of putting some of this on community activism as well, and that the responsibility of all of us as a community, and to Javier's point earlier, not just border states, but to all of us as a community to take some kind of action and to organize is really heartfelt. So I appreciate all of your time and attention, and definitely to Matt Garland and Sheila Sridhar for their leadership in this report. Thank you all.
Thank you. Thanks for moderating, Cristela.
Oh,
everyone.
pleasure. Thank you.